Naruvi Hospitals, promoted by the Sanko Foundation, is the brainchild of the founder-chairman Dr. G.V. Sampath. Belonging to Vellore, the medical hub of India, Dr. Sampath's vision to create a medical destination for the people of Vellore in particular and others from India at large and also overseas resulted in the establishment of a hospital here, a real crown jewel in the field of healthcare. Large numbers of people belonging to Vellore and the surrounding districts have been known to travel to Chennai and Bengaluru, both nearly 200 kilometers away from Vellore, seeking medical care due to the dearth of facilities and the hardships faced by the locals to access available services. As per the vision of the chairman, the best in healthcare, both in terms of medical and nursing professionals, as well as sophistication, were infused into the institution, making sure that patient affordability was addressed at all times. Less than a month after Naruvi Hospitals opened its doors to the public, the second wave of COVID loomed large as life. We took on the challenge and quickly rose to the occasion, catering to the local population and some from outstation as well, adding close to 40 critical care beds and over 200 ward beds to the COVID care pool. Much as it was hard for a 1-month-old hospital to handle such large volumes of very sick patients, Naruvi Hospitals was able to contribute significantly in our country's efforts to save people from the disastrous end that COVID was driving people to. Naruvi Hospitals is positioned as a high-end tertiary care center. Our focus on ethics, transparency, patient satisfaction, and an academic outlook in everything we do ensures that doctors, nurses, and others in the care team are performing at their conscientious best to not only treat patients' ailments, but also to make them happy overall when they leave our hospital. We have tied up with the Henry Ford Health System, HFHS, based out of Michigan State in the United States of America. HFHS is one of the old and leading healthcare delivery systems in Midwestern America. The main aim of this tie-up is to have constant transfer of knowledge and to get access to the time-tested practices they have been following for decades, which ultimately translated to patient care. Naruvi Hospitals is a completely paperless and filmless hospital. The Naruvi philosophy of care is embodied by our motto, Fragrance of Care. The doctors in Naruvi are largely trained in the best of medical institutes in India and come with years of rich experience in their fields of expertise. With the philosophy and its pallbearers, the medical and nursing professionals, the high-end equipment, and the building infrastructure complete the holistic picture of Fragrance of Care. The hospital is 475 bedded with a 25% critical care bed count. Naruvi Hospitals boasts of an over 5 lakh square foot building spanning 14 levels. The building is completely air-conditioned, conforming to ASHRAE standards with zone-specific air conditioning to reduce cross-infection between different care areas. Our laundry is 100% barrier washed. We have a top-of-the-line sterilization department with machines with 95% water-saving machines, saving up to 300 liters of water every running hour. We have all the major medical and surgical specialties. There are 16 modular operation theatres with laminar airflow. All the equipment in the ICUs and OTs are pendant mount to avoid clutter on the floor. All the departments are equipped to the most modern standards with the best and latest equipment so as to be able to provide the best end-to-end treatment to our patients. State-of-the-art cardiac cath labs, the latest robotic hybrid OT, ECMO, interventional pulmonology, high-end orthopedics, general and bariatric surgery, epilepsy monitoring unit with robot-guided epilepsy surgery, neuro monitoring, navigation, the latest lithotripter, urology laser are just some of the arrows in our quiver. Our primary focus, though being the local Vellore people and Indians at large, we are working towards attracting overseas patients as well. We have started an office in North Sudan in Khartoum. We're in the process of tying up with the governments of Oman and Seychelles as well. In all, Naruvi Hospitals is more than a hospital. It is an experience.
A happy Sunday morning and a warm welcome to our panelists and audience who have joined today's webinar, a part of the ongoing Healthy India, Happy India series presented by Naruvi Hospital's Vellore in association with The Hindu. Today's session is the 9th one in the 15-part series themed around prevent illness, promote wellness, and it will focus on arthritis. To explain the types and symptoms of arthritis and how it can be diagnosed and treated, we have a panel of 3 senior consultants in rheumatology, whom all of you can see on your screens. Over the next 1 hour, they will take us through this disease of joints, bone, muscle, and connective tissues. They will also bust myths around arthritis and take questions from the audience to clear all doubts whatsoever and give their valuable medical inputs. So I would like to start today's session by inviting Dr. N. Raja from Naruvi Hospital's Vellore. He completed his MBBS from Madras Medical College, Chennai, his MD in Internal Medicine from the Postgraduate Institute of Medical Research and Medical Education and Research, Chandigarh, and DM in Rheumatology from Madras Medical College, Chennai. With an experience of more than a decade, Dr. Raja has treated over 30,000 patients with rheumatic diseases. He has conducted numerous awareness programs for patients and continuing medical education programs for the medical community as well. So a very warm welcome to you, Dr. Raja, and over to you now for your presentation on types of arthritis and their symptoms.
Good morning. I'll share my slides.
Yes, sir.
It is full screen?
Yeah, it is.
Okay. Thank you. I would like to express my gratitude to our hospital, Naruvi Hospitals, and the Hindu team for this excellent initiative. Basically, it's a grossly misunderstood topic, arthritis. So we, as 3 of our panelists, we want to just make sure that the correct information is passed to the audience. Okay. So first thing is, what is arthritis? Arthritis is basically inflammation of the joints. So again, the question is, what is inflammation? Inflammation is, it's a medical term. The patient will have the following symptoms, which could explain the inflammation in the joints. Some people have pain in the joints. Some people may not have pain. They might have only swelling of the joints. Some people will have only that is when they get up in the morning, there might be redness over the joint. We call it as erythema. There will be limitation of movement of the joint. And if only left untreated, the joint will result, the arthritis will result in deformities. So what I would like to highlight is not all patients need to have all the symptoms. Some people can have only mild swelling of the joint, so only pain is there. Unless they see the correct specialist. What I would like to highlight is rheumatologist, because rheumatology is the department which deals with all these joint symptoms. So only the rheumatologist would be able to correctly pick it up. Next common problem which we face is joints. One word I want to tell for the local population is they feel mutu means only knee. So they say even if they have pains in the hands, pains in the feet, shoulder, elbow. So this are the, the diagram represents the shoulder joint. Consider that as a joint. According to them, joint means only knee joint. So it's not they call it narambolik. They call it as vague symptoms patients might interpret. The problem with this, if they don't recognize that these are all joints, they might end up in the wrong specialty, and the precious time might get wasted. So the point I would like to highlight is two. One is there are so many joints in the body, and not only knee is the joint. Number two is the symptoms of the arthritis, which I already previously told, not everybody need to have everything. As I, as I already told you, we have arthritis, but I would like to highlight the common arthritis, what we encounter in clinical practice and what we see in the general population. Rheumatoid arthritis is one of the most common arthritis which we see in our daily rheumatology scenario. We call it as mudakavadam in Tamil. So basically, it is more common in women, but it does not mean that men don't get affected. But it's predominantly a disease of women, and all age groups can get affected. The commonest age group is 30 to 50, but you can see 20 years, 15 years, more than 50 years. So any age group can be affected by rheumatoid arthritis. The point is many times when the elderly people get joint pain, it is tend to be ignored as you become older, so you're developing joint pain. And when very young people get, we tend that this age itself you're having joint pain because we worked with so much in our generation. So two extremes of misconceptions prevent the patients from reaching the doctors. And usually multiple joints are affected. The joints are affected on both sides. That we call it as symmetrical polyarthritis. Again, it is not a rule. The rule is that some people can have only one or two joints. We have seen patients with one knee joint having rheumatoid arthritis gets damaged. They get replaced. After few months, the another joint gets developed. So we should have a very, very high index of suspicion to diagnose arthritis. And again, rheumatoid arthritis is mostly a systemic disease. Many patients, at least 20 to 30%, can have eye involvement. They can have lung involvement, which is called as interstitial lung disease. For the general audience, it's again not to create a sense of fear, just to create awareness that rheumatoid arthritis is a joint disease, but it can affect organs other than joints also, especially lungs and eyes. If not treated well, it will lead to permanent joint damage, which the other panelists would be highlighting. So these are some of the pictures. What happens if you don't treat well? So this is the first picture is the picture in the upper left corner is the hand deformity. And the lower left is the foot deformity. So again, these are also joints, foot joints. And the upper right, you see the knee is permanently damaged. The joints are fused, which results in secondary damage, which might only get better with knee replacement. And the lower picture is the red eye in the you have scleritis, episcleritis. So just to create awareness on rheumatoid arthritis. Okay. Next common arthritis which we see is psoriatic arthritis. We know many people have psoriasis. It's a skin condition which they can have in the scalp, they can have in the back, they can have or anywhere over the body. We have to understand that a patient with psoriasis, if it develops joint pain, it should not be ignored. They should see a rheumatologist to see whether arthritis is there or not. Many times it is just tend to pass off that you have that's not given adequate importance. And another tricky point is sometimes arthritis can come first. That is, the patient can have joint symptom. After few months or years, they can develop skin lesion psoriasis. So as rheumatologist, we make a point that any patient with arthritis, we search for psoriasis. Many times the patients may, because they are not aware, they don't give the history also. So that is very important. This is one of the important arthritis. So there are various domains of psoriatic arthritis. These are pictures of psoriasis in the right upper corner. There's nail destruction can occur. And the right lower picture is showing the picture of psoriatic arthritis. It's very difficult for a non-rheumatologist to pick up and say whether it is rheumatoid arthritis or psoriatic arthritis. Again, there are specific patterns, the picture, the clinical picture, radiological findings, so many things will tell. So the third common arthritis is gout. This is very, very common, which we see. This one arthritis, which is more common in men. Most of the arthritis occurs in women, but gout occurs in men. Usually, it's an acute arthritis, meaning it's a very sudden, painful condition, affects only one joint at a time. Usually, the foot joint, the great toe. We call it as a metatarsophalangeal joint. But problem is, if you don't treat, the attacks come again and again, and over a period of time, it can lead to chronic deforming arthritis. So serum uric acid is the primary reason for this gout attack. So the left side picture is just a metatarsophalangeal joint. You see the redness, swelling. If you don't treat, it results in a gouty arthritis. Many times it is they give painkillers, the patient gets better, and they don't come for follow-up. So last two arthritis, which is very common, is one is ankylosing spondylitis. Again, it is a common problem which we encounter. Again, it's more common in men less than 45 years. Even you can have it in 10 years, 12 years, 15 years also. The predominant complaint is low back pain It's an inflammatory back pain. The only point which you would like highlight is this type of back pain is more with rest. If you walk, the pain subsides. That is called as inflammatory back pain. When you get up in the morning, they have a lot of stiffness. Over half an hour to 45 minutes, they start walking. If you don't treat, it can result in hip arthritis, fusion of the spine, and this condition can also cause redness in the eye, which is called as uveitis. See, this is just one of the famous pictures in our textbook where a patient stands upright over a period of decades. They bend forward and they stoop down. So the last arthritis is osteoarthritis. This is the most common arthritis. A lot of questions on this. Osteoarthritis is a disease of elderly, but this osteoarthritis can occur in young people also if you don't treat the rheumatoid arthritis, if you don't treat the psoriatic arthritis, if you don't treat the ankylosing spondylitis properly, they can have early osteoarthritis. See, the knee is the most commonly involved joint. Even other joints like hands can also involve. There are so many other arthritis which is beyond scope of discussion at this time because we need to answer more questions. So I would like to finish with this, and I would like to hand it over to the Hindu team. I
Thank
will stop.
you.
I will stop the screen sharing. The other person can. Okay.
Yes, thank you, sir, for that explanation. So after we know about the types of arthritis and how to identify the symptoms, the next logical step is to get it diagnosed. Our next speaker, Dr. M. Kavita, will give an overview of the lab test, imaging methods, and how to interpret the setting in of arthritis in an individual. She's from the Radial Road branch of Kaveri Hospital in Chennai. After completing her MBBS from Madras Medical College, Dr. Kavita did her MD in General Medicine from Tanjavur Medical College and DM in Rheumatology from MGR Medical University, Tamil Nadu. She holds a DNB and also SCE Rheumatology from Royal College of Physicians, UK. With over 10 years of experience in the field, she's adept at treating inflammatory arthritis, acute arthritis with intra-articular injections, and autoimmune connective tissue diseases. She uses biologics and newer disease modifying treatments, which reduce the dose and need for steroids to the bare minimum. An expert in managing highly challenging cases of myositis, and vasculitis, Dr. Kavita has special interest in treating systemic lupus and recurrent pregnancy loss due to antiphospholipid syndrome. She is the co-editor of the handbook, The Avant-Garde, Clinical Trials in Rheumatology, and has over 25 publications in the reputed journals to her credit. So over to you, Dr. Kavita, for your presentation.
Thanks for the introduction. As Dr. Raja said, I'm taking over from him. So he has explained us to the common types of arthritis. So it's up to us to. I hope the screen is seen, right?
Yes, ma'am.
Yeah, fine. Before anything else, arthritis is just not a disease. It's just a clinical sign, which means there is an inflammation around the synovium of the joints. That is what we all say. Arthritis is just a clinical sign. It per se does not mean any disease for that matter. So why early diagnosis? Why do we want an early diagnosis? Is any delayed diagnosis, we may end up with deformities. See, as Raja showed certain pictures of appellants where he was able to show a deforming arthritis. The moment we say arthritis to the patient starts crying just because they imagine having this sort of deformities in them in a longer term. That's not going to happen with newer disease-modifying anti-rheumatic drugs currently. With the advance in the management of rheumatoid arthritis, ankylosing spondylitis, we're not going to see this pictures anymore, like the deforming arthritis or the stooped up picture of an ankylosing spondylitis. So that is what we are here from. So the delayed diagnosis is actually meaning a permanent joint damage. So as rheumatologists, why do we create such awareness talks at all? Is that to capture people in the window of opportunity. The initial 3 to 6 months after your symptom starts, when your diagnosis is made, the right diagnosis is made and you're put on right treatment, and the chances that you're going to be pain-free for for the rest of your life and damage-free for the rest of your life is going to be a real possibility. I'm consciously avoiding the word called as drug-free because many of our diseases doesn't make us drug-free. It can be a damage-free and a pain-free movement, which a rheumatologist is actually watching for. And early intervention always slows the disease progression. This is what we have to capture the people at the window of opportunity. And if you ask me, how do you diagnose arthritis? I would say there is no single test to diagnose arthritis. So that's the most important thing. So you cannot see, if you want to diagnose heart attack or the myocardial infarction, you need an ECG TROP-T. Yes, do you diagnose in an acute event at all? But if you want to diagnose a rheumatoid arthritis or psoriatic arthritis or an ankylosing spondylitis or an osteoarthritis for that matter, there is no single imaging or a single test to diagnose arthritis. Well, we understand there are certain blood investigations which will aid us. There are certain imaging which will aid us. But again, there is no obvious single test. So starting from the clinical history, I would say the most important part is to see a rheumatologist and get a proper clinical history. The clinical history which tells us, which actually Raja told us, when it is going to be a long-term history, like more than 6 weeks, early morning stiffness is there. I'm not able to rotate in my bed or turn in my bed in the night times for spondyloarthritis. Or this arthritis started after an episode of diarrhea where we have reactive arthritis. We have seen patients telling us, I hardly had 6 hours of fever. Then the very next day, I'm not even able to move out. And the patient is wheeled into the OPD. This is like a typical post-viral arthritis. I sleep completely at night, had a party the day before. Maybe I had alcohol during that party, an excess of red meat consumption. The morning when I wake up, my toe is swollen, it is inflamed, I'm unable to land my foot on the ground. This is what a gout is. Irrespective of whether your uric acid is going to be normal, high, or sometimes even low, that is an episode of gout. So the proper clinical history is most important as a rheumatologist to diagnose whether it is a rheumatoid arthritis, psoriatic arthritis, reactive, post-viral arthritis. We could see some patients coming to us after an episode of fever with arthritis along with mild discoloration in their face. This is like a typical post-viral arthritis where we have a nasal discoloration which happens in the season of September to February in us. So next to the clinical history, I would say always a pattern. The pattern of joint involvement, which joint is involved. So we always have this pattern in rheumatoid arthritis where the hand joint is usually involved, the gout, the first metatarsophalangeal joint, which is the joint of the foot, is involved. The osteoarthritis, the knees are involved. The psoriatic arthritis, sometimes you have a dactylitis or a swollen digit or Achilles pain or a heel tenderness. All these things are pattern of arthritis which we actually depend on when we diagnose an arthritis. This is to emphasize on saying that there is no single test in diagnosing arthritis. Next comes the clinical examination, which we also see the joints as well as the other features. As Raja said, so there could also be some patients who are referred to us with interstitial lung disease, which is like lung disease on a dominant or the eye inflammation for the dominant, just to see whether they have a disease or not, because our disease doesn't stay with arthritis in the sense joints alone. It goes into the lungs, it goes into the nerves sometimes, it goes into the eyes, and there are lot many organs which can be involved. And apart from that, and investigations will also aid. So clinical history and pattern is the most important thing. Next comes your examination and investigations. In the hand itself, you have certain joints which are more involved in osteoarthritis. There are certain joints which are more involved in psoriatic arthritis. There are certain joints which is more involved in rheumatoid arthritis. So in the hand itself, if every single joint points to some other disease or not, so entire body has to be examined on a whole to say which sort of arthritis it is. Sometimes we finish all our history just to see a scalp patch like this, which is a typical psoriatic arthritis patch in the scalp, or a psoriasis in the foot, which straight away gives the diagnosis of psoriatic arthritis irrespective of your rheumatoid factor or not. So you can have nodules which are subcutaneous nodules or nodules in the foot which can say it is a gout, and then you have a skin rashes. Sometimes in apart from this arthritis diseases, you have connective tissue diseases like SLE where arthritis is also a feature. Then you can have palatal ulcers. There are multiple ulcers like this. See, when you go into investigations, there are two sort of blood investigations which we actually depend on. One is like blood investigations, other is the imaging. So we have patients who are happy to convince that they have a rheumatoid arthritis if they have a rheumatoid factor or anti-CCP is positive. This RF and anti-CCP are the two major investigations which we actually depend on in our diagnosis of rheumatoid arthritis, apart from our complete blood count, ESR and CRP, which in our terms we call it as acute phase reactants, which are usually elevated when they have an inflammatory arthritis. I say usually because many times can also be normal. So rheumatoid factor anti-CCP is positive. it is easy for us to put forward it to the patient saying that you have arthritis because these are positive in you and you have to be on treatment. This is slightly easy for us to convince. But when such patients can have a negative rheumatoid factor and negative anti-CCP, but their pattern of presentation is similar to rheumatoid arthritis and we have to treat such patients, it is difficult for us to convince. So which tells us there is an option called as rheumatoid arthritis, which can be seronegative, which means rheumatoid factor can be negative, anti-CCP can be negative, you still have rheumatoid arthritis. And that arthritis exactly believes like a positive rheumatoid factor and anti-CCP. Without treatment, they will also end up with deformities. So at least 30% of patients can have this antibodies negative. We call it as antibodies because these are antibodies which act against our own immune system. That is what is called as antibodies. This rheumatoid factor and anti-CCP are major antibodies in rheumatoid arthritis treatment. And then I come to uric acid, saying because uric acid hyperuricemia of more than 7.4 is the cutoff, but we usually see patients with gout having a uric acid in the level of 10 and above. That is where the first attack of a gout starts coming. So uric acid during an acute event can either be normal, it can be low, or it can be higher. But between the events, it is usually having a very high uric acid, which is called as hyperuricemia. And then certain joint pains will have this HLA-B27. This is something slightly important because many of these patients would come to us where they have done all the investigations, all are negative. Still they have back pain, still they have foot pain, heel pain. And then you see the B27, it turns out to be positive. It is actually a genetic inclination towards development of arthritis, as Raja showed you, the stooping up, which is like ankylosing spondylitis can have a stooped up disease. Then sometimes psoriatic arthritis can have this B27. Sometimes a mere uveitis, mere redness of eyes alone can have HLA-B27 positive. Sometimes a patient could have inflammatory bowel disease like a Crohn's, like a ulcerative colitis. If the patient has that, they will be knowing about all these things. So in that case, those patients tend to develop joint pains. This B27 can be positive. So this is a genetic test, which is, patients whom HLA-B27 are positive, is positive, like they have they have an inclination towards developing a arthritis. So ANA, because I told you certain diseases like lupus, Sjogren's, NCTD can also cause arthritis, which is usually diagnosed with anti-nuclear antibodies. Most ANA, RF, anti-CCP are all antibodies in our system. As I already told you, B27 is associated with so many other diseases. So, see, if RF is negative, anti-CCP is negative, and I want to objectively convince a patient of rheumatoid arthritis that you tend to have arthritis, all I go ahead and do is imaging. Imaging is MRI of the hands, MRI of the foot, whichever organ system or whichever part of the body is more involved in that patient, that can be subjected to a MRI. I put X-ray, I've also put X-ray, but X-ray will not aid you in the early diagnosis, because X-ray, the findings of X-ray starts happening much later into the disease. And sometimes you have an acute inflammation of the joints. You do a synovial fluid analysis, you can see a gouty crystal. That can also happen. But all things are negative. We sometimes do a bone scan and PET scan. There are slight extensions. Usually MRI, synovial fluid analysis and ultrasound of the part which is involved is the usual part of investigations. And this is an MRI of sacroiliac joint, which shows inflammation. This is a synovial fluid analysis showing a gouty crystal, which is the monosodium urate crystal. As we talk about the most common here. So with this investigations, with this clinical history, with the blood and investigations and imaging, we diagnose most people in this group. But some people in the outside of this group can have rare diseases like sarcoid, adult onset Still's disease, which are beyond the scope of this one. So where arthritis is also a feature. And some people will not have a diagnosis but still have arthritis. These are patients who are to be kept on follow-up. On the follow-up, these patients can develop a malignancy. This patient can develop some other diseases like myositis. And such are patients who have to be under follow-up with the doctor, because arthritis can evolve into some other diseases. As rheumatologists, we know whatever we see during that time is not going to be the forever diagnosis in patients. Patients do evolve, the disease to evolve. So the diagnostic challenges comes where there is an overlap and there is a seronegative RA, where can be atypical presentations, but all the more misdiagnosis is always equal to delayed treatment. To conclude, early diagnosis is always critical. It requires a combination of history, labs, and imaging. Tailored approach for each arthritis is important. Awareness among both patients and clinicians will lead to better outcomes and no more deformities. So awareness is the first step towards diagnosis, and also otherwise diagnosis is the first step towards healing. Thank you, and Sham will take over.
Thank you, Dr. Kavita, for your presentation. And before we move on to our final speaker, I would request the audience to post their questions in the Q&A box for our panelists to answer them later. So we now move on to Dr. S. Sham, who's also from Kaveri Hospitals, the Alvapet branch in Chennai. Dr. Sham has 13 years of specialized experience in managing various rheumatic diseases, including rheumatoid arthritis, spondyloarthropathy, gout, systemic lupus, psoriatic arthritis, vasculitis, and autoimmune diseases, among others. He has received advanced training in musculoskeletal ultrasound from prestigious institutions in the United Kingdom and Italy. Dr. Sham serves as the associate editor for both the Indian Journal of Rheumatology and the Journal of Royal College of Physicians of Edinburgh. Alongside his clinical practice, he has an interest in medical teaching and organizes regular continuing medical education programs for students and healthcare professionals. This MD, DM, MRCP from UK and FRCP Edinburgh degree holder, Dr. Sham is committed to advancing the understanding and treatment of rheumatic diseases. He advocates comprehensive approach to patient care, research contributions, and educational initiatives. Dr. Sham's talk is on treatment options for arthritis, including the role of steroids and emerging medications. The floor is yours, Dr. Sham.
Thank you, ma'am. I will share the slides. At the outset, I'd like to thank Naruvi Hospitals and the Hindu for this wonderful initiative. Actually, I had kept the background color as a bright blue with the sea background because generally for arthritis awareness, blue is considered to be the color for spreading awareness about arthritis. And similarly, unlike a couple of decades before, now the treatment has changed a lot. So it's not like before. We have a lot of newer options. It's pretty bright for patients with arthritis. So let's go into the topic. So we'll touch upon already my friends Dr. Raja and Dr. Kavita had spoken about the various types of arthritis. Among the arthritis, the one which is more common, which is more challenging both for the patient and for the healthcare provider like the rheumatologist is the rheumatoid arthritis. So having a very short time, like it can't be covering extensively. So just wanted to clarify on few myths and certain facts with regard to the management of arthritis. The first most important thing whenever I ask why the patient didn't come to the doctor for such a long time is they tell we don't want steroids, we don't want painkillers, because people generally think that these are the only two things are the main treatment options for rheumatoid arthritis, which is actually a big no. So steroids and painkillers are not the main treatment for rheumatoid arthritis. Actually, we have, for understanding, usually I tell us level 1, level 2, and level 3 drugs. So level 1 are the conventional drugs. Whenever we diagnose the patient early, we can start with these drugs called as disease-modifying agents, like methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. So only thing is these drugs, they take around 8 to 12 weeks for them to start acting. This is the reason whenever a patient is going to walk with pain to the doctor's OPD, the first thing you will be expecting from the doctor is a pain relief. Before I talk about the disease, whether it's going to involve other organs, how long he has to take, first and foremost thing is he wants to walk out pain-free. Because these tablets, the basic ones, are going to take around 8 to 12 weeks for them to start acting. Many times it's not possible for us to leave the patient in pain for the 2-3 months. That is the reason always we overlap these main drugs, the rheumatoid arthritis specific drugs, with a steroid or a painkiller. Generally, steroids are preferred considering the safety in short term. Many times, steroids are being continued over a long time, or patients think that they are the main treatment and the disease modifying agents are getting stopped. That shouldn't happen. So initially, for a couple of months or maximum of 3 months, combining a low dose of steroids with the disease modifying agent is generally beneficial as per scientific evidence also. The other thing is, if there are certain risk factors, like let's say the patient has a poor diabetes, then we do try to avoid steroids. Or if the patient has a kidney problem, we do try to avoid painkillers. So the drugs which are on this currently on this slide are the basic drugs. Majority of them, at least 70-80% of them, if they are diagnosed early, they do very well with these drugs. Only thing, at what dose, whether they are going to be doing well on a single drug or a combination of drugs, that's the question. If they are not responding to this drug, as I told a couple of decades before, there are not much options. Patients used to be continued on a low dose steroids, but now we have a whole lot of other molecules. Now we have something called small molecules. The one on the right, what we call JAK inhibitors, tofacitinib, baricitinib. There are a whole lot of newer molecules that are going to come. These I usually tell as a level 2 to the patients to understand, but actually both the biologics, all the other ones other than the tofacitinib and baricitinib are all injectable forms. So these are a level above the conventional drugs. So people in whom we are not able to control the disease with the conventional drugs alone, let's say I'm giving the patient on methotrexate and hydroxychloroquine for 6 months, still the patient has pain, or they are not able to come out of a steroid and painkiller, then we have to step up the treatment. That is the most important thing. See, if we have 10 different patients in our OP, each of them will be needing a different dose. It's not that all of them will respond to the same drug at the same dosage. So finding out what is the dose which is going to keep that particular patient pain-free, in the sense, patient should be pain-free only with a rheumatoid drug without a steroid and painkiller. That means the patient has the good disease control. So always, only if the patient is off steroid, if they are not taking painkillers on a long term, only they are taking rheumatoid drugs, whether it's the conventional or the newer ones along with the biologics or the small molecules, then only then we can tell the patient is doing well. And if the patient is going to need a steroid or a painkiller, it means the disease is not under control. It might be even a very small dose of steroid or painkiller. So coming to the steroids, there is a one option sometimes for a speedy relief. If the number of joints involved are just one or two, you can give a intra-articular steroid which acts locally. It is a very safe thing, but it's only a temporary thing. It's not a permanent thing. Just wanted to tell regarding this slide because many people think injecting into the joint is very harmful. It's not so. Particularly patients who are during the pregnancy or during the lactation, when we can't use the good drugs, many times for large joints, let's say the knee joints are involved, they are not able to walk. We give them intra-articular, which is absolutely no contraindication or no safety issue. Only thing is, it is not a long-standing or a permanent solution. Many times, 3 to 6 months, the patient might do well. By the time we have to step up the specific drugs for rheumatoid arthritis. So most important thing other than the drugs is the patient education. So always we try to take some time and educate the patient, if either in the clinic or through some other programs like this. So always know your disease. It shouldn't be that somebody else gives you the tablet, you just take the tablet. Know the treatment options. You have to ask your doctor what drug, is it a painkiller, is it a steroid, is it the disease specific drugs. This has to be discussed with your doctor. And most important thing, many times whenever a patient gets diagnosed with rheumatoid, it's going to be a long journey. So whenever they have a pain during this long journey, everything gets attributed to rheumatoid, which is not true. Because patients with inflammation, they can have this pain due to rheumatoid arthritis. Then the dosage of the drugs have to be stepped up. But sometimes when we see the patients a bit late, already as Dr. Raja told, there would have been what we call osteoarthritis or knee damage due to the underlying rheumatoid arthritis. In those patients, stepping up the rheumatoid arthritis medicines is not going to help. Or the patient is going to do some heavy work, they are going to have a tennis elbow, or they are going to have a neck pain due to cervical spondylosis. That is again not due to rheumatoid arthritis. Because knowing the cause for pain or discussing with that with your doctor is enough, because many times patients get frustrated that in spite of taking treatment, I'm still having pain. Along with the drugs, most important thing is diet, exercise or yoga, whichever you are comfortable. So these are very, very important. And whenever you are feeling low, sometimes even help with the psychological aspect is also needed for some patients. So early detection, as emphasized, is the key. The proper treatment in the initial 2 to 3 years and the regular follow-up with the rheumatologist is very important. Dr. Kavita told that drug-free remission may not be possible, but still there is a very small percentage people who become very early, bit less than 6 weeks or 3 months, if they're going to take proper treatment for initial 2 to 3 years. We do see a very small percent, like maybe it varies from less than 5% to sometimes even 20%, maybe 1 out of 4, there is a chance that they can come out of the drugs. So that is very important. Why to lose that chance? And we have to do regular monitoring to monitor for the side effects. Taking the drug regularly will take care of the disease. Monitoring with regular blood test will take care of whether the patient is going to have any side effects. If at all there is some fluctuations, we can adjust the medications accordingly. Always know that the specific drugs takes time for acting. That is the reason painkillers or steroids are given. And as I told, it has to be a wholesome management. Medicines are the key, but definitely the complementary thing along with that will be exercise, yoga, and a good diet. This slide is mainly to highlight patients with rheumatic disease, particularly rheumatoid arthritis. They can have a normal pregnancy. Only thing, the disease has to be under control. We have to change them to pregnancy-friendly drugs during the pregnancy and also lactation. For some diseases like connective tissue diseases like SLE or something like APS, we will be carrying out few more blood tests, and sometimes we might be giving few more medicines like blood thinners to prevent miscarriages. And sometimes you also have to monitor to look for congenital heart block. So the take-home message will be patients with rheumatic diseases, particularly young females, it's rheumatoid arthritis or SLE, they can have a normal pregnancy like anybody else. And the fertility rate is not going to come with this thing. Only thing is disease control and the pregnancy safe drugs which has to be started. So pre-pregnancy counseling discussion with your care provider, that is your rheumatologist, is most crucial. So next thing, spondyloarthritis, they are told it is something where the spine is involved in a major way. So the three main treatments, one, exercise or yoga is very, very important in spondyloarthritis, particularly with spine being involved. Swimming, cycling is very good. Initially, the treatment will be anti-inflammatory drugs. Then there are specific drugs like biologicals, which I showed in the previous slides with the rheumatoid arthritis, or the newer drugs like JAK inhibitors. Similarly, psoriatic arthritis, Dr. Raja was showing the various domains. There will be skin, there will be nail, there will be joint swelling. There will be points where the muscles or ligaments get attached, those called enthesitis, or the whole digit can get swollen, what we call dactylitis. Depending on which are the domains which are involved, the treatment options vary. So again here, like rheumatoid arthritis, we have the conventional DMARDs. If the patients are not going to respond to that, we have the newer drugs like biologicals. Different types are there which can be taken as like an insulin at home in a subcutaneous form. Sometimes we might have to give as a daycare in an injectable form, like as an infusion. And now we have the oral formulation of these drugs also. So osteoarthritis, we all know, it is generally a disease of the old age. Unless patient had a rheumatoid which is not controlled, they can develop osteoarthritis at an younger age. So treatment for this particularly will just restrict to knee. Most important thing is exercise, weight loss. There are no specific drugs for, let's say, knee osteoarthritis. Sometimes they can have a knee injections. It can be a steroid or a viscose supplementation. If the knee is really bad, like a stage 3, stage 4, then we might have to think about a surgical option. So diets, always try to cut down on your sugars, cut down on processed foods, try to avoid red meat, take lots of fruits and vegetables, spices and herbs. For gout, strict no to alcohol. In non-vegetarian, try to avoid seafood, red meat, try to avoid high sugar content diet. So these are the main things for gout. At the end of the day, all that matters is quality of life. Even if you are diagnosed with arthritis, you should have a normal life like as you had before the diagnosis. So exercise regularly, one of the most neglected part, which makes a very big difference, whether it's exercise or a yoga. And another important thing, all patients with arthritis, please check with your care provider whether you need vaccination, which is important to prevent certain infections. That the chances of risk of having those infections, particularly lung infections, are more in patients with arthritis. And another thing is, don't be worried about the side effects. Not that every patient is going to develop one. Always check with your doctor what are the risk of having a side effect with that particular drug and what you can do to avoid it. So what tests are to be carried out periodically. So every time just discuss with your rheumatologist. And just for the sake of this, please don't avoid the treatment, because you know it is always a probability. It is not a mandatory that somebody has to develop a side effect. And routine monitoring is the most key to get rid of the fear of side effects. So with this, I will wrap up my session. Thank you. Any questions along with my friends, we will be happy to answer.
Thank you, Dr. Sham, for the presentation. So I have just one question. We do understand that any pain in the joint or swelling in the joint is kind of a symptom for arthritis. So how intense that pain has to be, like you'll find, as you also mentioned, that people for the fear of taking steroids or painkillers, they don't go to the doctors. And many people you will find are massaging with oil and trying to do home remedies. So what I wanted to know is how intense that pain has to be, and also for how long. Many times it also happens the pain comes and goes, and people tend to ignore or neglect. So how would you elaborate on that?
Duration, it's easy. Like It's generally more than 6 weeks. Ideally, the patient should be evaluated. With regards to the intensity, it's actually more of subjective. So for practical reason, anything which impairs your daily activity, like particularly inflammatory arthritis, morning you get up, you're not able to hold your brush or hold your coffee mug or open the door. So anything which impairs your daily activity, then it means that needs attention. And with duration, it's more than 6 weeks.
This is just a myth, perhaps, because I have also heard people say the moment you hear the first creak sound in your knee when you're trying to bend it, so that is your first indication. Is that true?
That is
So
usually
you
for, okay.
Yeah,
Shanti,
please.
yes, ma'am.
It
Yes,
that
was
is
please.
also
usually for an
adherent.
osteoarthritis part of it, which is a mechanical joint pain. Usually, a slightly elderly people. The first myth which we want to clarify here is people with inflammatory arthritis forms the bulk of a rheumatology practice, which means early disease, like in the sense early age, like in the mid 30s or 20s is what rheumatoid arthritis. There you don't get the creaky sound. All you get is a stiffness. What we call it as the morning stiffness is something which we get both in the hands as in the back. The creaky joints is usually associated with osteoarthritis. Osteoarthritis is a degenerative arthritis, which is usually associated with the elderly.
Dr. Raja, maybe I could bring you in, like arthritis is also associated with the aging population. So what is
Yeah.
the reason, what is the reason for the not so old or the younger population getting it? And what is the earliest age that you have seen in your patients?
Am I audible?
Yeah.
Yes, sir.
Yes, Raja.
But there is some disturbance, there's some lag in your connection, I think, because even while you were making the presentation, but I didn't stop you because you had your slides running. But yeah, please go ahead.
Is it clear now?
Yeah,
Yes,
yes, sir.
Raja.
Yeah. Yeah. The point is, arthritis can occur in any age group.
Arthritis can occur in any age group. Okay.
Yeah, Raja, keep speaking. You're audible.
Yeah. So the arthritis can occur in any age group. It does not, it is the common age group is the middle age group, but it can occur in children. It can occur in elderly population also. If it occurs in children, it is called as juvenile arthritis, occurring before 16 years of age. If it occurs before 16 years of age, that is called as juvenile arthritis. And it can occur in any age group. So it's not fixed that a particular age group can occur. It's a myth that younger age group is not affected. So it can occur any age.
And what are the reasons? Are there any ways to prevent arthritis?
No. If you ask us preventing arthritis, osteoarthritis with adequate lifestyle modification, good strength training, keeping your muscles fit, osteoarthritis, which again I re-emphasize is a degenerative arthritis associated with age, can be prevented. But however, the younger arthritis, the juvenile arthritis or the rheumatoid arthritis part of it, I would say could not be prevented. To some extent, lifestyle modifications can help in delaying the disease, but it is many times autoimmune, which means the immune system plays havoc. We tend to get it. Is treatable, but prevention-wise, slightly difficult here.
Just like
Yeah,
to
yes, sir.
add a point, only one of the preventable risk factors will be smoking.
Oh,
So
okay.
smoking is a strong risk factor for rheumatoid arthritis. So it's not just for cancers or other things, cardiac disease. So rheumatoid arthritis, ankylosing spondylitis, smoking is a risk factor. So that is only one of the preventable risk factors. But otherwise, like Dr. Kavita told, other things like infections are not really in our control. Like.
Mm. So there are quite a few questions and I'll start running through them. Arvind Rao is asking, how do we keep our joints healthy at all ages? And you have mentioned some specific diets which should be taken or not taken for either gout or rheumatoid arthritis. So, but is there any general specific diet and general regime of exercise which even a healthy person should do?
So generally for the bones, it's not just for the joints. For the bones, basically we need one is calcium and another thing is vitamin D. So calcium, all the milk products or like a ragi, spinach, tofu, nuts, all these calcium will be there. Vitamin D, of course, we have to go out in the sun. But still, Indians, for various other reasons, in spite of going out in the sun, we don't produce enough vitamin D. So many times we might have to take vitamin D in a supplementary form. because many of our food products are not really fortified with vitamin D, unlike Western countries. So these are the two things which regards to in general bone health. The what I showed is with regards to rheumatoid arthritis. So there is something called anti-inflammatory diet, basically nothing but a healthy diet, like low sugars, low carbs, less of processed foods. If they consume non-vegetarian, more of seafood with which has a lot of omega-3 fatty acid and less of red meat. So these are in specific for rheumatoid arthritis. Gout, as I told, again, like alcohol and among the non-vegetarian, both seafood, it's generally good for many of the conditions, but for gout, for uric acid, it may not be good along with red meat. And again, sugars and processed foods are a major culprit, whether it's rheumatoid arthritis or gout, or even for osteoarthritis to reduce weight, cutting down on our sugars, processed foods, and maybe carbs also definitely helps a lot.
Dr. Kavita, what is the connection between menopause and arthritis?
See, in general, to any of the arthritis, women's hormone does play a major change. So, in a patient who has rheumatoid arthritis much early, see, sometimes it is associated with either menarche or sometimes after a childbirth, because where the major hormones in the body changes. And in a patient with a pre-existing inclination to have rheumatoid arthritis, such hormonal changes sometimes do have an issue. Menopause is sometime where the hormone changes are there, which can, I would say maybe it is a second hit towards rheumatoid arthritis. That alone is not the cause. But menopause is sometime which can have an inflammation increase that is causing rheumatoid arthritis, or certain diseases called as Sjogren's has been associated with menopause. And most likely from the menopause starts your osteoarthritis, which means the estrogen becomes low, in turn the bone health becomes low. So more than arthritis, I would say the degeneration, osteoarthritis, which is a mechanical pain, along with osteoporosis. Both of these things are most associated with menopause rather than rheumatoid arthritis or other diseases. Yes, we do have an association because hormonal changes do have a association when it comes to females. But again, menopause, I would be more concerned about osteoporosis as well as osteoarthritis rather than anything else.
Dr. Raja, does one type of arthritis lead to another? Because Kapil Kumar says that his mother was diagnosed with RA and later doctors said that she has SLE. So he's inquiring whether they are connected and whether there's a progression from one kind of arthritis to another.
See, the rheumatological diseases evolve over time. The point is, initially the symptoms might be non-specific. So then the initial diagnosis would have been made as rheumatoid arthritis. But later, when the clinical picture is clear, the picture would have changed into another disease, that is SLE. So the problem here is only when the disease is well established, we can clearly make a diagnosis early. But many times the symptoms are non-specific and the initial presentation might be like one rheumatological disease, which might evolve into another rheumatological disease. So always a close follow-up with the rheumatologist is essential.
So there's a slight
because it's not a very rare thing to see a patient have diagnosed with one illness shifting to another thing.
So there's a slight echo in your audio actually. You have to.
What Raja is trying to tell is the disease can change. Like initially it could have been rheumatoid arthritis. Later it could have changed to SLE. So rheumatic
many times in our diseases that does happen. Disease modifies itself. So that is the reason we often tell seronegative arthritis, we need to a very, very close follow-up. Sometimes it turns to some other connective tissue disease, many times during the course of the treatment. Yes, it's not uncommon in our practice.
Indranil Roy wants to know the specific diagnostic tests for psoriatic arthritis.
As I told this before, there is no specific diagnostic test to tell whether it is rheumatoid, psoriatic, or whatever arthritis it is. Many times it is the pattern of arthritis, the what joints are involved, seeing in the acute phase reactants like ESR-CRP and a psoriatic patch. So that those are the things which will tell us whether it is a psoriatic arthritis or not. But there is no basically specific test. Of course, we depend on X-ray sometimes and MRI sometimes just to see whether there is an inflammation or a bone marrow edema inside.
Aman wants to know how does one treat uric acid accumulation in the body, as it is also known to affect joint pains, and is the Febustat tablet the only solution for it?
So,
Dr. Sham, would you like to take
yeah,
it? Yeah.
uric acid, when it accumulates, we call it as gout. So whenever there are one or more than 2 episodes of gouty attacks, like patient has a joint pain, then better to start them on what we call uric acid lowering drugs. So as he has rightly said, there are 2 options as of now available in India. One is febuxostat, the other one is called allopurinol. So these drugs have to be taken over a long period of time, at least few years, if not for long term, lifelong, so that or whatever uric acid has got deposited in the joints will get washed off. The initial 3 to 6 months, we also might give some anti-inflammatory drugs like colchicine. But once the uric acid comes to less than 6, the patients, at least minimum of 3 years, they have to take these drugs along with lifestyle modification. So in uric acid, lifestyle modification is equally important, like taking these tablets regularly, like weight reduction and also diet.
So he's also asking about treatment for ankylosing. What is it?
Ankylosing spondylitis.
Spondylitis, because he has pain for last 3 years in backbone, and his pain radiates to his leg region, and the body becomes stiff. He's not able to properly sit for more than an hour in the chair, and he's already taken many painkillers, but those he finds are just temporary management.
Has to be evaluated properly with an imaging, with a rheumatologist or with a spine surgeon, then diagnose what it is, whether it is an ankylosing spondylitis or just a lumbar disc disease because he has got a radiating pain to the leg, and then get a treatment. I would say maybe a Vipitan is not the right place to offer the treatment protocols. Evaluation, proper evaluation is the necessity.
Okay. So Sitaram wants to know, like, to prevent the pain from arthritis, like, of course, you are also talking about lifestyle change and food habits change. But then if a senior citizen, a real elderly person already has a lot of pains and all, so how do you kind of bring in those lifestyle changes in terms of exercise or therapy? And also if obesity is an issue, what are the solutions?
Who do you want to ask, ma'am? Raja will take.
Dr. Raja?
Basically, if it's a knee joint which is involved in elderly osteoarthritis, the primary thing is weight reduction. So it's not very easy to reduce weight when you are older and you are obese with knee pain. The walking and treadmill, all those things are not a possibility. Like what Dr. Sham was telling, the primary thing is reduce your diet, meaning reduce your sugars and processed foods and reduce your weight. Diet is the primary modification here. The good diet in osteoarthritis will help you to reduce your weight, which can prevent the knee pain. And for even for other inflammatory arthritis, a diet is the primary factor where you try to avoid your artificial sugars and processed foods, which helps in a long way. So even whatever the age, I think the diet pattern can be followed by even elderly population, even if they are a diabetic or accordingly manage accordingly. But other than that, what we recommend is walking in a level ground for a knee pain is fine. Only thing is they should avoid walking on uneven surfaces or climbing stairs. The better advice to use Western toilets. All these things are possible in elderly. And the only problem here is in our setting, still many times, even if you consider any population who become older, they're working, the workplace still does not have lift at many places. So those things are a big hindrance for the elderly population. So what we recommend is weight reduction is the primary modality for knee osteoarthritis in elderly population.
And word on the strengthening exercise, many times when we tell exercise, patients think it's a very tedious one. Strengthening exercise is as simple as sitting in a chair and doing some basic exercises. So that can be well done, just lifting the legs, holding up, or keeping a pillow, towel beneath and press. So it's a very simple one. So strengthening exercise, however severe the osteoarthritis knee pain, still people can do it.
And another question of yoga also comes here. Because they ask with knee pain, can they do yoga? The question is there are some postures which need to be avoided there also. Some asanams where they squat and they bend the knees, those things. So it is, see, the yoga is definitely a good thing, but it is not equivalent of physiotherapy. Sometimes the false conceptions occurs that the knee exercise is the yoga exercise which they do for the knee pain, which is not many times true. A good physiotherapist should guide them.
I would say
what
yoga
to avoid
stretches.
is important here. What is avoiding some certain postures are also important, which we see commonly.
Yoga stretches, strength training is slightly different. So I would say stretching therapy for ankylosing spondylitis and certain diseases, strength training for almost all diseases. So both of them should complement each other. cannot replace each other. That's something which I would say.
So somebody's
Somebody asked-
complaining about fingers hurting and swelling. Somebody's facing for almost 2 months. So he writes, I don't know he or she, but writes that I have trouble bending them just after I wake up. Though the pain subsides after a while, I still do not feel normal movement when I bend my fingers. So is it related to arthritis? And there's a similar
Definitely,
question. There's a supplement question also. Another person, Rama Prabha, is saying that for the last 20 days, I am experiencing some difficulty in movement of my right hand fingers. So should I seek immediate medical intervention? So basically related to your hands and fingers.
needs
Hmm.
evaluation. Definitely
Yeah,
needs
needs evaluation.
evaluation. Because again, morning stiffness, inability to flex the hands, disturbing their day-to-day activities. So always it need not, their pain intensity need not be very, very high. And it could just be altering their day-to-day activities, and the very fact that they are ready to sit and listen to the webinar and ask this question tells us that these patients need an evaluation by a doctor, preferably a rheumatologist. And then if investigations are needed, they can proceed on with it. Yes, but they have to see a doctor.
So does rheumatoid factor positivity reading of more than 100 necessarily mean that you have to start RA medication immediately?
Generally, the patients have to be symptomatic. The high rheumatoid factor just tells that it's a true positive. Many times these antibodies can be positive even few years before the disease starts. So the patient should have joint symptoms. As of now, somebody who is totally asymptomatic with only blood test being positive, there is no evidence to tell that we have to start them on treatment. So they have to have some morning stiffness, joint swelling or joint pain for us to start on treatment. Just an isolated positive patient is absolutely fine. It's still not recommended to start them on treatment.
And somebody who's on treatment for a longer period of time is also now beginning to feel tingling and numbness in the limbs, and the pain has not totally subsided.
So whenever
It
Again,
says 8 years,
again,
for
we have
8 years.
Sure.
Yeah.
whenever a patient on arthritis, if the symptoms are not getting settled, first double confirm that the pain, as I told, is due to inflammation only. If yes, step up the medications or change the medications. Always look for other causes. Since tingling is to do more with nerves than joints, always look for other causes for pain or whatever might be the discomfort. Then that has to be addressed.
Geeta has seronegative polyarthritis with restricted movement, and she's on sulfasalazine and HCQ. She wants to know what free movements could she do.
Raja.
What the question is, what is her exact question? She's on sulfasalazine and HCQ. What
She's
she
a
wants to?
seronegative polyarthritis with restricted
Okay.
movement, and for some relief, she wants to know what free movement can she do. She has restricted movement.
Her movement is
Of which
restricted.
joint?
She wants to know
Of
what
which?
she can do to have a free movement, for that movement
Yeah,
to
see, the
not
point is, I just make sure that first she consults a rheumatologist, the primary thing, because is the diagnosis the exactly the same, and uh, and the medications whatever she is taking is not like it's not as already Dr. Sham said, we have more drugs to add. Primary drug methotrexate, I think she is not taking. So the point is whether the diagnosis is rheumatoid, and if that is true, then I think she needs to step up treatment and physiotherapy of the concerned joint. Movement means which joint is the main thing, whether knee or hand joints is the difficulty. Accordingly, exercises, physiotherapy for those joints, and stepping up treatment. Again, the like what Dr. Sham was telling, primarily whether all these complaints are because of rheumatoid arthritis is the primary thing. See, patients can have rheumatoid factor of even 100. They might have having only low back pain. They might have some vague muscle pain. So that does not make it as rheumatoid. So the clinical pattern is what which is important here. In those patients, and even this same patient, if you're seronegative arthritis, we need to evaluate what is the reason for stiffness. It could be a rheumatological reason. It could be just early osteoarthritis. So many things are there. I think the examination plays a key role here.
Sushmita is diagnosed with osteophytes in cervical spine. And there is degeneration in both knees, and her lumbar 4, 5, and S1 disc bulge. Are all these due to arthritis?
Sham, I've already answered this question.
these are more suggestive of what we call a degenerative disc disease, something like a spondylosis, cervical spondylosis. And again, just to like to clarify that to all the audience, arthritis is just like using a term as fever. So we have to find out what is the cause for arthritis, whether it's osteoarthritis, rheumatoid arthritis. So here the cause could be more like a cervical spondylosis, something like osteoarthritis of the spine, like a degenerative wear and tear, which can happen as we age, or spondylosis can even happen in younger age group also. There are other factors.
So when you suggest drugs, and those drugs are also known to affect maybe kidneys. So somebody, Sandhya, is asking, should we use Ayurvedic drugs? Would they be useful in arthritis if somebody is also having other
The
issues?
biggest myth I would like to clarify when it comes to arthritis is the drugs affect kidneys and the liver. See, most of the drugs which we use doesn't affect the kidneys at all. Some drugs pass via the liver. So the point with allopathy is we understand what we are treating, with what drugs we are treating, and we are very much aware of the side effects of the drugs. So we make it a point that we monitor the side effects. We keep doing investigations on a regular aspect. We don't give outrageous claims that they will not have any side effects. No, we don't give that claims. We understand the limitations with which we work. So what we normally do is we follow the protocols where in the initial 2 weeks, we start the drug, we monitor. We monitor with the complete blood count, we monitor with the liver function test and the creatinine. We repeat it at 4 weeks. And then once we achieve the target drug therapy, we do it every 3 months. Just to notice that any other side effects is creeping in. 95 to 96% of the time, there is not going to be any side effects. Maybe for 3 or 5%, there could be still side effects, which we can pick up at the earliest because we follow up with investigations. We pick up at the earliest, stop the drug which can be causing the side effects, which we are aware that these are the drugs which are causing the side effects. So we try to stop them or intermittently or temporarily stop, treat with another drug or replace with another drug or reduce the dosage of the drug. Since we are aware of the side effects, we monitor them very closely. And we don't give outrageous claims like no side effects with that treatment. No. And considering alternative therapy, I don't think we all practice allopathy. I don't think I can claim on what others say. So I stick on to this.
Yeah, so I'll skip because there are lots of questions on the side effects of continuous use of drugs, which is the main fear of people, and whether homeopathy helps, Ayurveda helps. So I'm just skipping all that. And somebody's asking, Suhas is asking, why does a person develop arthritis and different kinds of arthritis? Is it to do with your immune system?
See, basically, there is no single etiological reason to say why a patient develops arthritis. It's like multiple factors are involved, some genetic factors, some environmental factors, which are not very clear. So, as of now, the only risk factor which we can tell is smoking. So, if at all somebody wants to prevent arthritis, they can stop smoking. That is the one thing, both active and passive. Otherwise, there is no specific reason. But some people develop arthritis with the significant family history. Some people with ankylosing spondylitis, if they're HLA-B27 positive gene, they have a high chance that their children or their sisters can develop a thing. Again, the another common thing is why we develop arthritis. Suppose my parents have arthritis, will I get arthritis? So it's not that everybody is going to get. So what the best we can do is we can't keep worrying about it. We can just consult a rheumatologist immediately if you have a joint pain. I think various types of arthritis, we've already highlighted all the types of arthritis. Of course, there are much more, but this point I would like to highlight. Nobody knows why exactly we develop.
And can it be cured in a permanent way, or one has to be medicine dependent lifelong? Like we talk about blood pressure or.
We don't use the term word cured here. We tell the term remission. Patient does not have thing. And again, with drug or without drug is a question. Without drugs, if the patient is going to be completely in remission, I think a significant population will get treated very early. That is the reason we are telling to consult a specialist who is dealing with the joint symptoms, rheumatologist, who will help you, the population, general people, to get treated early. Once you get treated early, the advantage is the number of drugs generally needed to induce remission is also less, and the chances that you might be able to totally stop drugs or maintain a very minimal dose of drugs is very high. Again, I feel that we must not make any disease as a taboo. It's okay if you have a disease, let us accept it. Like Dr. Sharma was telling, get treated and live happily rather than denial. That is the main problem here. We don't want to anybody to tell that we have a disease. I think the other panelists, it's an important question. They can even share their inputs on this cured and not cured because
Uh, yeah, a lot
Generally,
of
other
people,
than
sorry.
other than infections, I think most of the diseases which you have can't be cured. They can be only controlled. It's an infection only. You give antibiotic, take it out of the body. So as Dr. Raja told, to put in simple terms, these diseases you can make it sleep. So when the disease wants to wake up, it depends on that individual and his or her disease severity. If somebody has a mild disease, it might sleep well, sleep for a longer time, might even take off drugs. But if somebody has a bad disease, it might keep waking up. So totally depends on the severity. So we can't remove it from the body, but we can just give the drugs and make it sleep so that it keeps calm.
So as you, Dr. Kavita, did mention that, you don't really want to, I mean, you can't comment on the alternate systems of medicine. But then there are questions like, people are now following a lot of WhatsApp university messages, and people take turmeric in milk, people take cinnamon water, and they think it will reduce inflammation and it will, in some ways, perhaps reset their immune system. So what do you have to say to that? What advice would you give?
The fads of anti-inflammatory diet, we aren't sure about it. Like, there are not many scientific trials on that. All these things, as you already have mentioned, WhatsApp and YouTube's systems has a lot many anti-inflammatory diet which we are not aware. But obviously, maintaining a good diet with a cut down on carbohydrates, increasing the fibers in the content of in the food, and even protein intake can be increased. All these things are good. So, see, our disease treatment protocols slightly change over a period of time. In current state, whatever evidence is there towards the diet, we follow it. And the diet evidence currently says cut down on carbohydrate, increase your protein and fibers. That is the perfect anti-inflammatory diet which we can follow. For the gout part of it, as already have been explained, Sham, multiple times here, avoiding seafood, though it is a protein-rich diet, avoiding seafood is most important, and cutting down on alcohol. People start concentrating on diets a lot, but the most important thing here to cut down on your alcohol and cut down on your smoking. See, following all the diets and increasing, adding up smoke or adding up, alcohol in their day-to-day activities is not going to change anything. So leading a healthy lifestyle is most important. And all the other dietary fads are dietary fads as such. See, scientifically, whatever we have, we have spoken on is what science says. And apart from that, everything else, I need evidence before I comment on that. Yeah, curcumin, yes. Sometimes even in osteoarthritis, curcumin is more towards improving the joints. The curcumin is generally related to turmeric. People do add turmeric in milk, and organic turmeric should be okay. But other than that, spending a lot on such fancy diets is not going to help us.
So
I
is
would
it a
like
myth?
to,
Yeah.
I would like just to add one point. The point here is like Dr. Kavita was telling, how much curcumin, how much ginger,
We
who
normally
knows?
don't know.
Suppose you say ginger it's going to prevent arthritis, going to prevent cancer. How much ginger we are going to take? Do we have any dose? Do we have any studies? How many grams of ginger to take per day?
Nothing is
Do we
science
have an
there.
answer? We don't have an answer. So each then it cannot standardize to the generalized population. No, everybody will take their own amount of anti so-called the diet which is going to cure an arthritis or it's going to reverse a malignancy, which is not possible because there is no standard data to say you take 5 spoons of turmeric per day. We don't have, no. So that is a big problem here. All this can supplement, but the treatment part is the essential here. You have to get treated by a rheumatologist for arthritis, and your all other things will be supplementary. That's what I feel in
Arthritis
this.
alone that cannot be treated alone with the diet part of it.
That can
That is
help,
So
most
but may not
important.
be the primary factor.
So is it a myth or a fact that dairy products should be avoided in rheumatoid and gout?
No, I would say it's a myth. I insist on increasing their dietary consumption of dairy products because it has lots of calcium in it. It is actually good for the joints and bones. And we have heard patients telling that they don't go along well with pulses. They don't go along well with root vegetables. See, but science doesn't support it. But if they feel like their pains increase after a certain diet, stop it. That's maybe individualized for them. Apart from that, our science doesn't support stopping dairy products or stopping root vegetables or stopping pulses. for rheumatoid arthritis. Yeah.
See, for gout, actually, dairy products help. But again, as Dr. Kavita told, see, when it comes to diet, we don't have adequate evidence. It's very difficult to do scientific studies. So if somebody feels milk is going to worsen the rheumatoid pain, you avoid it, but make sure you take calcium in some other form. That is important. So we shouldn't cut one totally the main source of calcium, and we shouldn't be lacking calcium. So take through some other form, like ragi, or as I told, spinach or something. If you feel strongly taking a milk is worsening your rheumatoid pain, you can avoid it. But make sure you supplement the same mineral or vitamin in some other form, because it's totally individualized. Many times we shouldn't be arguing on it, but main thing is it's always complementary. People with mild disease always escape, they might escape without a treatment. But what we are speaking in a forum like this is the ones who really need treatment. So along with treatment, these things can be a complementary, but not the main, this one, like just a diet alone to get rid of all the symptoms.
There are multiple questions on PRP therapy. What role it plays and is it helpful?
The platelet-rich plasma therapy is usually used for an osteoarthritis, the degenerative arthritis, grade 1, grade 2. It is up to the orthopedicians to decide on whether they are candidates. But with my response to platelet-rich plasma therapy, inflammatory arthritis, all throughout which we have been talking now, is rheumatoid arthritis, ankylosing spondylitis. I haven't seen much improvement. And our guidelines do not suggest that. So if we are practicing evidence-based medicine, the usage of PRP in inflammatory arthritis is ideally questionable. But maybe in osteoarthritis, grade 1, grade 2, I think the orthopedicians are the best persons to talk on that and whether they find improvement. But my experience with that is very, very limited, and I don't find much of an improvement in inflammatory arthritis. In some patients, it actually does exacerbate or increase the level of arthritis, which they have been already having. Yeah.
The point I would like to highlight is, no, patient has knee pain or some joint pain. Let them first consult a rheumatologist and make a diagnosis, whether it is an inflammatory or rheumatoid arthritis or it's an osteoarthritis. The problem here is only with a knee pain, without diagnosing whether it is rheumatoid or not, to get a PRP injection may not be very useful. That's what we are trying to tell. If the diagnosis is osteoarthritis in early stages, PRP injections are useful in a selected group. For some may be beneficial, but if it is going to be a rheumatoid, it is not going to be beneficial. So who is going to decide whether it is a rheumatoid arthritis or osteoarthritis is a question. So that point is very clear. Only when they make proper diagnosis, then the PRP injections might be beneficial in some people. Just for knee pain, you cannot go and take a PRP. May not be very useful in this.
Right. Thank you for the clarification. I'll have to end the program. So one last question. Does stress or anxiety or pollution or any of those external factors also lead to arthritis?
They don't lead, but they complement it. There is a lot of association with a happy mind and a good stable joint. Patients do feel very comfortable with treatment if they are stress-free, if they are less anxious, and they are very happy with their life. But again, stress and anxiety definitely does increase the level of pains, though not directly inflammatory. They do contribute to neuropathic pains and other pains. Those things are definitely complement the increase in the pain perception whenever we treat a patient with arthritis. That's how yoga helps, meditation helps, keeping ourselves stress-free and keeping ourselves happy. Doing our regular activities and hobbies do help. So not concentrating on continuously scrolling through videos of inflammatory arthritis is going to do more harm rather than good. That is what I would say. The entire mind has fixed ideas. They start scrolling, and our Facebook feeds has this habit of giving you feeds which you search on very frequently. So that comes as regular for them, and their entire life is concentrated on arthritis. Arthritis is just a part there. We are going to treat it. They're already on treatment. They're going to improve with that. But keeping your mind stress-free does help, does play a major role in keeping a patient pain-free too, along with our own drugs. I think other panelists can talk on that.
Would you like to add something as a final wrap-up, Dr. Sham and Dr. Raja?
No, means I do concur with them. Like, yes, diagnosis and medications are the key, but definitely people who do other things, like whether it's exercise or yoga or a healthy diet. And see, all of us have stress in our life, but at least some way to counteract it, or to at least to some extent. Definitely those type of patients, they do very well. So it has to be seen as a wholesome. And other thing is the family support. That is very important. any of the family members of patients here, like in this webinar, please understand these patients do suffer sometimes symptoms like fatigue we can't see from outside. It's not that every time the joint has to be swollen, pain should be there. So support is very, very important. We have to understand their issues. And whenever people who have a very good family support, those are the patients whom I see they do very well, along with, of course, the other things like exercise, yoga, diet.
Okay, so I think I'll bring it to a close. There are still a lot of unanswered questions, and some people have written in requesting all the doctors to answer them offline. And many people also want to go back to your presentations because it carried a lot of valuable information. So for their benefit, I would like to say that the session has been recorded and can be viewed again later on YouTube. But I think doctors, you should kind of answer the questions because there are plenty which have remained unanswered. So I would like to thank really Dr. Sham, Dr. Raja, and Dr. Kavita for giving your time and especially on a Sunday morning and clearing so many doubts and all your valuable inputs. And also I would like to thank all the joinees who have sent in their pertinent questions. And I hope some of your doubts have been cleared and we will have our doctors replying to you. So thank you all, everybody, for joining today's webinar on understanding arthritis, which was presented by Naruvi Hospital's Vellore in association with The Hindu under our 15-part series, Health India, Happy India. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Good day. Bye.